Hi, and welcome to Procedure Ready OBGYN, a podcast aimed at helping you excel during your clinical clerkship in OBGYN. My name is Dr. Jennifer Dory. I'm an assistant professor of obstetrics and gynecology at the Johns Hopkins University School of Medicine and former resident at Thomas Jefferson University Hospital. I'm the founder of Procedure Ready, a collection of resources aimed to advance your clinical medical education. Let's get started. Today, we're going to be talking about what you need to know before your first colposcopy and LEEP. So first off, what are colposcopies and LEEPs? These are things you probably heard about very briefly during your second year lecture, but don't see a whole lot in the office. But you very well will run into at some point during your office portion of your OBGYN rotation. So colposcopy is essentially looking at the cervix with a microscope and using different solutions to highlight areas of abnormality. How do you get to need a colposcopy? So the reason we do colposcopy is usually after an abnormal pap smear that was done for cervical cancer screening. So if you take a look, there's a group called the ASCCP. They run the guidelines and publish the guidelines on the correct protocols for how to respond to abnormal paps and sort of the reasons that you end up at a colposcopy. These are guidelines that by no means do you need to memorize, but they are sometimes things that show up on the shelf in terms of, does somebody with an L-sil pap, how do they best get managed? Which means usually a colposcopy, or somebody with an ascus pap, an abnormal but unknown significance pap, get managed if they're young and healthy, in which case it's usually follow-up with repeat pap. So just knowing and being familiar with the general concepts behind the guidelines can be helpful, although you really don't need to memorize them all. The link to the PDF for the guidelines is in the description of the podcast below, and there's also an app you can get on your phone if you're thinking about going into OBGYN. It's $10, but it keeps you up to date and has a really nice algorithm. So either that or download the PDF to have on your phone so you can take quick peeks at things and look really smart on the wards. All right, so let's back up a second and talk a little bit about cervical dysplasia and what's actually causing us to need a colposcopy. So cervical dysplasia, cervical cancer in general, is a completely preventable form of cancer in the developed world. We have one of the best screening tests around for it, which is a combination of the pap smear and the HPV testing. So cervical cancer is caused by a virus. It is caused by HPV, or the human papilloma virus. It is a sexually transmitted infection. The two most common, most virulent strains, the most commonly causing cervical cancer, are the strains 16 and 18. Those two were the first two that were developed into a vaccine called the Cervarix. Nowadays, you guys probably hear more about Gardasil. Gardasil protects you against not only these most common kinds that cause cervical cancer, but also the most common kinds that cause genital warts. So HPV is responsible for both of those things: cervical dysplasia and cervical cancer, as well as genital warts. So it's preventable by vaccination and by screening and then treatment before it turns into cancer. So the goal of screening is to find any precancer, any dysplasia, before it turns into frank cancer. So we're able to pick up abnormalities. The way we talk about abnormalities are on a scale of 1 to 3, with one being abnormal, but potentially reversible. 2 and 3 being more concerning for a progression to cancer, but 3 still being not cancer, it's still dysplasia, and then eventually cervical cancer comes after that. So what we're trying to do with the colposcopy is take a look at the cervix, figure out why we had abnormal cells on our pap smear, try to figure out exactly where those cells came from, identify an area of concern, and then take a biopsy of that area of concern if necessary. Things to also be familiar with, you might get asked about during a colposcopy or a LEEP: what are the risk factors for cervical cancer? Smoking, other sexually transmitted infections, including HIV, anything that essentially could reduce your ability to fight off a virus in the vagina or in the cervix. So, or anything that causes immunodeficiency. So chronic steroids use, immunosuppression for an organ transplant, any of that would put you at a much higher risk for dysplasia and cervical cancer. So talk briefly about the histology, not my favorite topic, but something you got to understand at least a little bit of when we're talking about colposcopies and LEEP. So the cervix is made of squamous cells on the outside, on the portion of the cervix that you're going to be looking at. There's also the endocervix, which is the canal, which has glandular tissue. And then there's what we call the squamo-columnar junction, which is from the outside, those squamous cells that are going to be mostly what you look at, and then the columnar glandular cells that go through the canal. The squamous cells are going to be most commonly what we're talking about. It's what the pap smear is meant to pick up and screen for. And what we're going to do is we're going to look at the cells under the microscope in a couple different ways. We might just look at them outright and see if we can see anything abnormal. Very atypical to see something abnormal. That typically means it's pretty advanced if we can see an outright lesion. To pick up dysplasia, more oftenly, we're going to put on a solution of some kind. The first solution we see often used is acetic acid. The exact mechanism of how acetic acid works is unknown, but atypical cells, if you remember from, first and second year of med school, atypical cells often have a higher nucleus-to-cytoplasmic ratio. So they have more dense nucleus compared to the cytoplasm, which is the less dense area of the cell. So the acetic acid turns that nucleus white. So the cells that are abnormal that have a higher nucleus to cytoplasmic ratio appear whiter. So they cause what we call acetowhite change. So when we put the acetic acid on the cervix, if it turns white, those cells are considered more likely to be abnormal. We're looking for patterns of change within the cervix itself. So acetic acid and looking for acetowhite change is the first thing we're going to look at on a colposcopy. The second thing we can look at is something, or a solution we can use is Lugols. Lugols is an iodine-rich solution. The iodine reacts with glycogen. Glycogen is in normal squamous cells. Should be there in the cell. So if these cells turn iodine stained, if they turn dark brown, they're normal. So unlike the acetic acid, which is abnormal cells will turn a color, with Lugols, normal cells turn a color. So for Lugols, we're looking for non-staining cells. Those will be our abnormal. So that's the important difference to remember. So acetic, we're looking for the ones that change to white. Lugols, we're looking for the ones that don't change. So we can see several things by applying this acetic acid in the Lugols. We can see what we just call HPV changes, which are sort of diffuse changes without any clear pattern. We can also see things like increased vascularity. We can put a green light on the microscope and see vessels pretty well. So we can see abnormal vessels because, as you know, cancer, precancer, all of these things are very good at recruiting vascularity because they demand a lot of blood supply and nutrients to grow. We can also see things called punctations, just essentially little puncture marks on the cervix. There's indrawing of cells, which is pretty pathognomonic for abnormality. There's also something called mosaicism, which kind of looks like a reticular or a lacy pattern on the surface in terms of which cells are picking up the acetic acid or the Lugols. And then any contour changes. So just like when you're looking at breasts and doing a breast exam, if there's dimpling, if there's not a smooth contour, if anything has changed, there's a raised area, there's a depressed area, there's an ulcerated area, anything like that. If you see something abnormal, that's a sign of something not quite right, and we're probably going to take a small biopsy. So during the colposcopy, most people will end up taking some type of biopsy. The reason being, there's been a couple papers that have shown an increased detection of CIN II and III, even if you take random biopsies, even if you don't see any changes. So we typically err on the side if the person had a higher grade PAP, or if we're concerned, or if they're older or have any risk factors, err on the side of taking a biopsy or two. The way we do this is we take a tiny or a small instrument called usually a Kevorkian forceps or something of that nature to just take a small little, essentially not scrape because it's got some depth to it, a little bite out of the cervix. These are not comfortable. The woman usually does not have any anesthesia for this, not even lidocaine on the cervix. So it's not exactly comfortable, but it gets the cells you need to tell if we got cancer or anything. So after that colposcopy, if everything looks normal, we take the biopsies, they go to the lab, they'll come back a week or two later. If a patient has CIN II or III, that's typically when we're going to say, all right, let's talk about doing an excisional procedure, meaning removing a portion of the cervix. So if we take out a portion of the cervix that has the abnormal cells, she essentially gets to start over. There's a chance with CIN and with II and III that she can heal it. And I usually tell patients, I think of HPV like a really bad cold. Most people at some point in their lives are going to have some strain of HPV. It's super common. Hopefully less now with the vaccines out there, but still, people are going to be exposed to it. The question being, how well does your body fight it off, and how completely does it fight it off? It's normal to come in contact with it, and your body should be able to fight it off. Most people who come in contact with it when they're young will fight it off, but it can remain down in the basal membrane of that cervix and create problems with long-term abnormalities in terms of long-term abnormalities of PAPs, and then eventually turning into cancer after many years of being dormant. So that's why we watch people with abnormal PAPs pretty closely for a prolonged period of time to make sure it's not going to turn into something. But on the bright side, we usually have it about 10 years to pick up an abnormality before something's going to turn into cancer. That obviously changes if you have other risk factors, things that are going to decrease your time before you develop cancer. Again, people who smoke, who have HIV, who are immunosuppressed, things like that are going to be more likely to develop abnormalities and cancers faster. All right. So if we have to do an excisional procedure, the most common excisional procedure performed is a LEEP, or a loop excisional, a loop electrocautery excisional procedure. Sorry, I just finished a night shift. I'm on my third week of 7 of nights. I'm getting a little loopy. So a LEEP is an in-office or in OR procedure where you take a small piece of the cervix out with essentially a wire that is looped. It works as similar to a bovie. It has a monopolar current and is a wire that essentially can cut off the end of the cervix most commonly. Ideally, you do it in a single pass with an emphasis on any areas that looked abnormal with the acetic acid, or if you had a prior biopsy, you know the abnormalities at 12 o'clock, you're going to try and get a slightly bigger piece from 12 o'clock. There's also something called a top hat if we're worried about an abnormality in the cervical canal itself. So if we had a reason to believe that the atypical cells could be glandular or columnar, like we talked about, that they could be coming from inside that canal, we'll do something called a top hat, which is a smaller piece focused really on that endocervical canal. So that's the LEEP. That's the most common procedure you're going to see. The slightly less common procedure is something called a cold knife cone. This is something that nowadays is really performed primarily by gynecologic oncologists with particular reasons. So not just people with low-grade abnormalities, but people with higher-grade abnormalities, cervical canal disease, so somebody who had an abnormal endocervical curetting, so an ECC, or atypical glandular cells that are coming from their cervix, might be people who get a cold knife cone. The other time we do a cold knife cone is if somebody is pregnant but thought to have early, potentially high-grade CIN III or early cancer, they can get a cold knife cone to try to remove that and allow them to continue the pregnancy safely. There are more complications with the cold knife cone because, as the name implies, it is a cold knife. It is a scalpel cutting into a very vascular portion of the body, which is the cervix. So there's just slightly more blood loss. It takes a larger piece of the cervix, or not a larger, a longer piece, meaning it goes up towards the uterus more. So it's associated with slightly higher complications. So that's why people tend to favor the LEEP when it is clinically appropriate. But if you do any rotation with gynecologic oncology or anything, you might have a chance to see a cold knife cone. They're pretty rare. So if you do, appreciate the experience. All right. I think that's pretty much it. So really, colposcopies and LEEPs. Know about your acetic acid. You're looking for acetowhite change. Abnormal cells will turn white because of that high nuclear-to-cytoplasmic ratio. With Lugols, it's iodine rich, and the normal cells will take up the iodine. So the normal cells will turn dark brown. So you're looking for the non-changing, the non-staining cells. HPV causes cervical cancer. Protect people, whatever you go into, encourage people to get the HPV vaccine. It saves a lot of women's lives. And it's good for men too. They carry the virus and pass it around. So get everybody vaccinated if you go into peds or internal medicine or OBGYN, really whatever. Encourage that vaccine if you can. LEEPs for most cervical dysplasia, and then cold knife cones really for higher grade stuff that the gynecologic oncologists are really taking care of these days. Thanks for listening to Procedure Ready OBGYN. Hope you found today's podcast helpful. Don't forget to subscribe below, rate the podcast, and leave me a review. Your reviews seriously make my day, every time. Have you done your pediatrics rotation yet? We just launched a new Clerkship Ready Pediatrics podcast to help. We're always looking for new collaborators. If you know a phenomenal medical educator who should make a procedure-ready or clerkship-ready podcast for their specialty, pass along their information and we'll see if they want to collaborate. Finally, check us out at procedureready.com for more helpful resources like our flashcard deck and our YouTube playlist.